We welcome everyone today to our fourth webinar in our COVID webinar series. Today, we will be discussing supporting your perinatal units during COVID-19, outpatient care, and patient education. This webinar is co-hosted by CMQCC and CPQCC. I am Courtney Nisbet, Associate Director of Quality at CPQCC. Thank you for attending today's webinar. Our past three webinars in our COVID-19 series have focused on research and practice guidance and mental health support of patients, families, and healthcare workers. Today, we will start with a brief snapshot of the current state of COVID-19 in California. Then we will shift our focus, and a multidisciplinary panel consisting of maternal and newborn clinicians will answer questions around outpatient care and patient education. Next slide, please. Just want to go over a few webinar logistics. All attendees are automatically muted upon entry, and the chat feature has been disabled. We're asking that you please utilize the Q&A box if you're having technical difficulties, and also to submit any questions you have for the panelists. We will be selecting a select number of questions relevant to the topics presented, and the remainder of the questions will be used to inform the topics of future webinars in this series. Next slide, please. I want to take a moment to highlight our joint CMQCC and CPQCC COVID webinar resource website. This was launched on March 24th. It has been viewed over 38,000 times since it has been launched by over 18,000 users. We want to make folks aware of this COVID-19 resource and encourage you all to share and utilize with your colleagues. Of note, the slides and webinar recording will be made available on the site later today. And due to the rapidly changing guidelines around COVID-19, they may be taken down after 2 weeks. Feel free to email us for more information. Next slide, please. I want to highlight our disclaimer and that the information shared in this webinar series and on our resource site are examples of how hospitals, healthcare workers, and families in California are responding to COVID-19. We understand that each hospital is working with a different set of resources and constraints, and as such, some of the recommendations presented may not be applicable to your hospital setting. Guidelines and recommendations should be adapted to fit your local needs. And as this is a rapidly evolving public health situation, we encourage you to take into consideration the most recently available local health department and CDC guidance when developing your internal protocols. Next slide, please. I would like to highlight and welcome our presenters today. Dr. Elliot Main will give us a snapshot of the current state of COVID-19. And following Dr. Main, these multidisciplinary maternal and newborn clinicians will be addressing pre-submitted questions along with questions submitted during the Q&A during the webinar. We thank each and every presenter for their support of this webinar. Next slide, please. I now have the pleasure of introducing Dr. Elliot Main, Medical Director of CMQCC. Elliot?
There's a fair amount of data out there for states and even communities, but there's very little data on obstetric populations. So what we have put together in California is a leadership group of folks from every, nurses and physicians from every university, hospital in the state, and every hospital system in the state, which covers almost 2/3 of the births in California. We've been meeting weekly and have learned a lot from each other as we've shared our practices and shared our experiences. So I'm going to, after a few slides about the population level data, we're going to talk about what we have learned about obstetric cases of COVID in California. Next slide. Just to start with, on the right-hand side of this figure is the reported cases and the reported deaths by day in California. As you see in the top right panel, we had a couple of occasions in which it looked like the cases were going down in California. And I think our governor was pretty excited about that. But then each time that has reversed. We are kind of in a static of about 16 or 1,800 new cases a day, possibly related to better testing, particularly in Los Angeles. But you see in the bottom right panel that the death rate is also stable at about 75 deaths per day. This is in marked contrast to the left panel, which is New York. This is New York as a state as a whole, and they've had essentially 10 times or more the deaths and the cases per day. You can see that the death rate in New York State peaked at 1,000 deaths per day. We got a few days at 100, and we're now at 75. New York has come down markedly, and you can see their death rate is now about 150, which is still twice the rate of what we're seeing in California. It should be noted that New York is half the size of California, 19.5 million versus 40 million. Next slide. What we see also in California is big variation by geographic location. You can see in the top panel that the raw counts for California, i.e. just the counts per county, of course, will show Los Angeles way at the top, being the most populous county in California. So it's fairly important to look at a rate graph, which is the bottom half of this figure. And again, Los Angeles has the highest rate per million population of any county in California. San Francisco, San Mateo, San Diego, just as some examples, are in the middle with approximately half the rates of Los Angeles. And a couple of counties that were early on, like Santa Clara County, that was one of the first counties to report cases in California, have been pretty flat over the last 3 weeks. The red lines represent our weekly reports as we discuss with each other, and you can see that Los Angeles over the last 2 to 3 weeks has really jumped in the number of cases. Again, case counts are really only, can often be related to the frequency of testing. Nonetheless, when you do it per million, i.e. in a rate, New York City comes in at 22,000 cases per million, whereas even our highest rate, which is Los Angeles, is 3,000. 22,000 per million is 2% of the population is COVID positive, tested and positive in New York City. Again, next slide, we're going to show the death rates in California. Again, the raw count certainly puts Los Angeles way at the top, but what we're looking for is the bottom, is the rate in deaths in California is pretty strongly focused on Los Angeles at 150 deaths per million. So you can see San Diego, San Francisco are relatively low rates. There's been a total cumulative death rate in San Francisco of about 30 per million. Sacramento, it's interesting, is very flat and below any of these. So contrast that on the left with the cumulative deaths per million. Again, Los Angeles is our highest, 150 cumulative deaths per million. New York City is 2,300. Unfortunately, what gets on the television news and that our patients are seeing is stories from New York, New Jersey, and Connecticut. And that is not really representative of what we're seeing here in California. So nonetheless, we all, at the beginning of this, saw that studies, and most of our approach has been based on work that was being reported in New York and New Jersey. But that has generated, again, a lot of fear and concern in our patients. Next slide. As we discuss the situation in the state with the leaders that I spoke to at the beginning, we see a very different picture even in obstetrics. It's been a surprise to all of us that the number of obstetric patients that are seen on our tertiary and even our secondary obstetric units is pretty rare. Most of our units are seeing 1 or 2 cases per week, and many have seen fewer. again, there's some geographic variation and some variation over time. In Santa Clara County, there was a peak earlier that seems to have tapered off in obstetric patients. There have been only a handful of pregnant and postpartum ICU admissions around the state. Even in our big health systems, there's reported 2 to 3 to 4 cases over the last month, in each representing a denominator of 30,000 patients. Most have been, even those who've been intubated have recovered and discharged. Interestingly, there was multiple ones that were in the second trimester. In the last 2 weeks, there's been a huge interest and excitement for universal rapid COVID testing, i.e. testing everyone who presents to labor and delivery, ideally with a test that would be returned within an hour or two. So far, the rate of positive tests among asymptomatic women, importantly asymptomatic, which is key for understanding the population frequency and for reassuring our staff as to who they have to worry about and who they may not have to worry as much about. The rate of test is actually quite small, somewhere around 1%, maybe a few that are 2%. Many in this that have been reporting out have been less than 1% positive among asymptomatic pregnant women. This is in contrast to New York City, where the big hospitals there are reporting 20 to 30% positive tests among asymptomatic pregnant women. Again, likely reflecting the patient population that are the general population that's being served in New York City. A couple of interesting clinical points that we've seen in COVID, in these relatively small numbers of COVID positive OB patients, again, emphasizing second trimester illness, cholestasis, and the risk for blood clots and the need for anticoagulation for symptomatic moms. As the weeks have gone by, locations with very low incidence are considering some relaxation, that is, in quotations, because like the general community relaxation, that's unclear what that means and how that's going to be rolled out. There are a few of the hospitals that, for example, are now including doulas in their patient care mix. Others are being more relaxed around PPE, particularly in patients, asymptomatic women who are COVID negative on screening. And others with very, very low incidences are backing off on universal screening. I'd like to point out in the next slide, one of the key features that we always have to pay attention to that has a lot of national interest, which is racial disparities. This is the latest data from California, both for deaths and positive cases. This is California as a whole, with the California population on the right, and the deaths and positive cases by race. So American Indian Alaska Native has no reported deaths. Asian are about the same in terms of their population frequency. Black mothers or Black people in the population. This is not pregnant women. This is not women. This is the entire population. Is 6% of the California population, 10% of the deaths. This is seen all around the country where there is a disparity here. In Chicago, big news this week, 30% of the population in Chicago is African American, 70% of the deaths are African American. We're seeing an addition here, but it's not that scale because the population numbers in California are only 6%. Latinos, which is our biggest segment of the population, do have more positive cases, perhaps related to enhanced screening now in Los Angeles area, but their death rate is proportionate to the population, et cetera. So the last slide, in the next slide, is some of the sources for this data, which I'm going to will be available obviously when you download the slides. Next slide, I'm going to turn it back over to Christina Aldini. Thank you.
Thanks, Elliot. It's Krista. In the wake of the rapidly evolving COVID-19 pandemic, providers and community support entities have had to approach prenatal, postpartum, and pediatric care in new ways to best serve their patients. Our panel discussion today focuses on care in the outpatient setting and how it has been impacted by critical public health recommendations. Questions for our panelists have been supplied by registrants prior to the start of the webinar. We will ask additional questions that come through the Q&A function as time permits. For information and guidance regarding inpatient care, please see our website, caperinatalprograms.org. There you will find resources from our previous 3 webinars, including the full recording of Supporting Your Perinatal Units During COVID-19, Mental Health Considerations for Patients and Healthcare Workers, and the associated slide deck. I'm eager to learn about the innovative ways that our state has adapted to the current situation and turn the panel over to Christina Oldini, Associate Director of CMQCC, and Courtney Nisbet, Associate Director of Quality, CPQCC.
Next slide. Thank you, Krista, for getting us off to a good start. Elliot also. Here are our panelists today. We're very fortunate to have a great mix. And we'd just like to go ahead and get started. So our first question for the group is, what are the concerns right now of your patients or clients? How have you changed your practice to respond to these concerns? I thank everybody. They're going to allow us to use their first names today. So we're going to go right up North Humboldt County to Carrie Griffin. Carrie?
Hi. So I am a family medicine doctor who focuses on maternal child health. So my entire practice is actually obstetrics and pediatrics. And I would say that I work in 2 communities, a native health community, as well as a small reproductive justice-based private practice. And the main concerns are for people who are still pregnant. If they are essential workers, there's a lot of concerns about, am I safe? Is it okay for me to be interfacing with the public, even with the minimal PPE that's available in any number of different settings? Lots of questions about, should I be starting my pregnancy disability early? Elliot already alluded to this by mentioning that some hospitals are weaving doulas back into their permissible visitors, and one of our local hospital is, but support in labor, who's allowed to be with me. One of our hospitals had all support people leave 2 hours after baby was born. And the next day when I came into round, you could just hear weeping through the hospital. That was awful, and that actually changed. And luckily, our epidemiology here is low enough, and our curve has been quite flat until actually the last 3 days, and we've been able to support that. 3, the safety of the hospital. How safe is it to even go to the hospital? If people call and they're worried that they've ruptured, should they go in? Should they stay at home? So lots of worries in that regard. And then once baby's here, people are very concerned about who can meet my baby, how can I safely introduce this new member of my family to my family and the community at large. I would say those are some of the main ones, and I know other people will cite more issues in their communities.
How has your education changed in order to meet those concerns, Carrie?
So for a lot of what we have done, really for us, it comes back to staying up to date with what's been coming out about COVID and encouraging social distancing, reminding people again about our local statistics. And I think what Elliot's point did so well is what's happening in California is very different than what's showing up on the news day after day in areas that have been hit harder. So reminding people that good hand hygiene and not touching your face and being mindful of people who do have symptoms and absolutely isolating from them. In terms of support in labor, we have been lucky enough, again, to have doulas. And what's been tricky is the local politics of 2 small hospitals where now people are leaving practices and the one hospital they were planning to deliver at to come to the hospital that is allowing doulas. So, working on a community level to frankly try to encourage the same practices at both hospitals. And I would say that the other piece in terms of who can meet my baby, we're really supporting social distancing pods. So the idea that you identify 5 to 6 to 8 people whom you're seeing on a regular basis, you're not seeing people outside of that pod, you're practicing social distancing and good hand hygiene when you see each other, because especially for brand new moms, if they have a mother who would like to help and meet their grandchild, we don't want to discourage that at this moment, but again, all within the context of being reasonable and being honest about symptoms and possible exposures.
Thank you, Carrie. Erin, can you take us down to LA and what concerns of your patients down there are?
Sure. Thank you, everyone, for joining. I would just echo what Carrie had already mentioned, certainly about support both at home and in the hospital. Additional questions that our patients are bringing up relate to how severe the disease could possibly be in pregnancy, and certainly by trimester what the differences might be on fetal effects. I think the other thing that we're getting a lot of questions about are the best practices for folks in pregnancy, as Carrie alluded to, whether it's sort of workplace preparedness and safety practices, or just general, practices in the home. In terms of our patient education, what we're doing is the same. We're trying to be honest about what is known and what is not yet known about both the maternal and the fetal effects. As Elliot mentioned, we haven't thankfully seen the same impacts of COVID-19 in the pregnant population as previous viral illnesses such as H1N1. And while we're grateful for that, I think it's important for physicians, for providers, and health systems to make sure that we have essential services, starting even earlier on, like contraception remains available, that options for pregnancy termination remain available for those who are early in pregnancy and choose to take a different course. And then for folks who are, staying pregnant and going on towards delivery, that we provide information in real time about the changing understanding of COVID, both in pregnancy and certainly, newborns and beyond. In Los Angeles, we've established a warm line for our Los Angeles County Department of Health Services patients to call about COVID. We're providing information in both English and in Spanish regarding what our recommendations are. And we're really trying to be presenting a unified message in coordination with our Department of Public Health about the maternal child health messaging that is being delivered. It's certainly a challenging situation as the evidence changes sort of on the daily, and some of it we might wish we had earlier on. But I think we, continue to provide that same caveat that, folks should reach out and keep asking questions if they hear confusing or conflicting information, particularly as it relates to how to stay safe and what might be an acceptable workplace environment, for somebody who is, currently pregnant, and how to try to do what they can to stay safe and healthy for the duration of their gestation and beyond.
Elizabeth, come back up to Santa Rosa. Anything different that you're hearing that's in relation to your practice and what we've heard from Erin and Carrie?
Thank you. No, I would say that our families are expressing all of those concerns that Carrie and Erin both described so beautifully. I will say that what we're hearing as the constraints of COVID and the social distancing continues now into its, 7th week, are really very practical questions of how do I keep doing this? Things like, who's going to watch my kids while I go sit at the lab for 3 hours to do my 3-hour glucose test? Who's going to make sure that I have enough data on my cellular plan to support my telehealth visits and my children's learning from home? And these are very real and often very distressing concerns. So we have tried to structure our care in a very practical sense. So we've moved a lot of the services that we normally referred out for, like lab draws, in-house. We've introduced parking lot care kits and parking lot prenatal visits for folks who don't have childcare and can't leave and do need a face-to-face visit. And we've changed our education around the social distancing to something very similar to what Carrie described about our support pod. So identifying a core group of people that will be able to help you during your pregnancy and in the immediate postpartum period, so people are feeling more supported and less isolated.
Excellent. Pamela, why don't we take it over to the pediatric side? Could you share what your patients and your families are concerned about?
Sure. I will definitely add a voice to the choir of concern for what the effects are on new parents as they're losing their village that they normally would have in the postpartum period, helping them care for the baby. So we are very cognizant of the fact that this is more difficult than it might be during normal times. The other thing we've really been trying to focus on with our parents is that it's still very, very important to come in for their child's well care, especially in the first 2 years. So we've really focused on making our office a very safe space where, we're seeing well visits very separate from sick visits, and we're spreading out patients so that nobody's waiting in the waiting room, because it's really a priority for us that the young children continue to get their vaccinations on time. Immunization rates across the country have dropped dramatically during this COVID crisis, and we certainly don't want to see a measles outbreak or a pertussis outbreak simply because people were afraid to go to their pediatrician's office. So that's been one of our major focuses in the office, as well as expanding telehealth as much as we can so that parents really feel like they can still always reach us for every concern that they have while not having to come into the office. So we've been doing that, and what we're seeing more and more of as time goes on, and we don't know how long this is going to be going on for, is parents really with a lot of concerns about the social and emotional development of their children. What is this doing to the infants who aren't seeing other people outside of their families? What's it doing to the toddlers who aren't going to daycare or preschool anymore? The school-age kids who are missing their friends and their teachers, and the teenagers who are just bereft at not seeing their friends.
Yeah, thank you, Pam. And I think before we move on for a new question, I'm going to include our representative from Wic down in Southern California. This is the largest Wic program in the United States. So Wendy, can you tell us what's
Thank you.
You're welcome.
Yeah. Well, as a nutrition and breastfeeding program, Wic participants' concerns are a little bit different. One concern, especially early on, was access to Wic Services. And all Wic Services are available to participants throughout the state of California. Of course, we've changed how we are delivering those services. We're providing them remotely, either by phone, text, or online. We have a few agencies that are providing some breastfeeding assistance by Zoom, or a few still in person, I understand. Early on, we heard questions about access to Wic Foods and the availability of the formula. Access to Wic Foods does not seem to be as much of a problem right now. The state responded by providing an expanded Wic approved food list. So there are other food options for those that are having difficulty finding the foods that are in their food benefit. And the formula issue doesn't seem to be as much of a concern right now. I think early on in the pandemic, there was a lot of hoarding, and that seems to have calmed down. We're hearing from our breastfeeding moms more concerns about not having enough breast milk, and that's understandable because they're leaving the hospital with less breastfeeding assistance and support due to earlier discharge. And then another concern that both participants and staff have, at least at my agency, are concerns about babies who are not back to birth weight at 2 weeks. And some report that they're not easily able to get back to the doctor's offices for follow-ups and weight checks. Others say this is not a problem. And I will say that at least at my Wic agency, one of the things we're considering right now is purchasing scales that we will be sending out to our participants' homes, at least those that are having concerns about a slow weight gain or not back to birth weight, so that they can do some of that monitoring in their homes, and we can do some close follow-up with them. And because all of our services are remote, we have a lot of information and education available, both on the cdph.ca.gov website, wealth of information there. And each local agency has their agency's websites with a lot of material, information, video clips, and the like. So we are making sure that our participants are getting all of that information, and we're keeping them connected.
Excellent. I'm going to turn it over to Courtney Nesbitt, and we'll go from there. Courtney?
Hi, thanks, Christina, and thanks to all the panelists addressing that round robin question. I'm going to transition to the newborn pediatric population, and my first question is for Pam. Should mothers who test positive upon giving birth take their newborns in for testing on a regular basis?
The current recommendation is just for the baby to be tested at 24 hours and then 48 hours, whether in the hospital or as an outpatient, and then no further testing after that. We do tell parents to watch for symptoms, monitor, of course, for any kind of symptoms in a newborn, regardless of COVID or not. But there is no recommendation for ongoing testing of the newborn.
Thank you, Pam. I think we'll move on to see, I have a question for Sandra out of the HRIF clinic. How has COVID-19 and shelter in place affected HRIF programs in California? And just to reiterate, HRIF is the High Risk Infant Follow-Up Program. Go ahead, Sandra, thank you.
Hi, Courtney, thank you. High-risk infant follow-up programs in California have been greatly affected by COVID-19. Historically, high-risk visits have occurred in person. So most programs, there are 69 high-risk programs in California. Many have had to close during this time. Some have been able to transition to virtual telehealth visits, while others have moved to telephone visits. And there are a few clinic sites that are continuing to see some children with in-person visits. Additionally, what we have found across the state for high-risk infant follow-up programs, that many of our programs are impacted by reduced hours for employees due to the financial impacts of COVID-19, and that we're finding also that the overall amount of time and energy needed to provide comprehensive services to our children and families has increased substantially during COVID-19.
Thank you.
Thank you, Sandra. Go ahead, Christina, we're going to toss it back to you.
Thank you, Courtney. So this is kind of has two aspects to it. I'm going to give the theme of depression, whether it's postpartum, during pregnancy. We know the high rates of depression that occurs during pregnancy. So I'd like to throw it to Erin first, and we'll follow up with Carrie. What support is out there? Whether it's through office practices, community, public health. Should you be experiencing depression while you're pregnant or during the postpartum period? We know that patients are at risk for dropping off the radar after their discharge from a birth facility. So depression, anxiety, pregnancy, postpartum.
Thanks so much.
Erin?
And it's also coming through the chat box to address whether we're seeing more of that.
Right. So I'm happy you bring up this important topic, and I have the pleasure of working with a reproductive psychiatrist in LA County on our program, our Mamas program, and it's really an extension of the CPSP program that provides enhanced psychosocial support for moms on Medicaid or Medi-Cal. So, certainly for folks who do qualify for CPSP services or beyond, clinics who do have additional psychosocial support services are always a nice resource for those moms who screen positive and might be currently seen in a facility where there aren't those additional kind of hands on deck to provide enhanced psychosocial support via, counseling or other types of services. In our program, we have both community health workers who can do sort of basic resiliency type health education and support to licensed clinical social workers and therapists. And then obviously for folks who end up with more, severe, profound mental illness, or even sort of mild to moderate depression requiring medications, that's when physicians should be involved to act early on persistent symptoms and provide medication when necessary. By and large, OBGYNs, midwives, family practice physicians who provide maternity care should be able to prescribe mild to moderate depression medications such as SSRIs, which is within their scope of practice. And then for those who have severe and persistent mental illness, certainly additional warm lines or access to reproductive health psychiatrists provide that extra layer of support. And so I would encourage folks to really get to know that network in their local geographies for that, place-based response system that might be available. Dr. Dossett, the reproductive psychiatrist that I work with, has been, working at the state level for quite some time, and wants to make sure that we highlight the postpartum.net website, which is the website from Postpartum Support International. And again, this doesn't just apply to postpartum, as you so well described. This is really anything from that first prenatal visit or even preconception care, where additional needs for mental health services are identified. But there's great information on postpartum.net for professionals. There are places to navigate for patients to help get support, and just a variety of really important resources for folks to access. We see a high burden of mental health need in our clinics to start with, with something like 30 to 35% of our patients screening positive for mental health needs, which is, something like 3 times that of the general population. So we're quite responsive to these needs at baseline, but certainly we have started to see the increased impact that COVID-19 is having on mental health, with increased calls to the suicide hotline here locally, where there may have been less than 20 calls a month previously, jumping to sometimes over 100 a month in the last couple of months. So that's certainly a concerning indicator. CMQCC did a really nice review, although of a very unfortunate sort of silent epidemic of perinatal suicide. And I think this is an important, really important topic that we pay attention to. Telehealth, I think, has been instrumental in helping to provide an additional layer of support for folks, even if remotely. And that can be, practiced by, any member of the OB care team, including, psychiatrists when involved as well, through a variety of different telehealth platforms. And we really all need to be engaged in making sure that those services are both screened for, and then, that our patients are connected to them expeditiously, since this is taking quite a toll, I believe, on our patients.
Thank you, Erin. Carrie, anything to add? I think
Carrie, you may be on mute.
Yeah.
There we go. The double unmute. Thank you all for your patience. So Erin summarized that so beautifully, and so many of our responses in Humboldt have been very similar. The only thing I would add would be twofold. Is one, at our monthly chart reviews at both the Native Clinic and then the small private practice I'm at, we're trying to identify, in fact, using CPSP at both those practices, people even earlier, and doing a little bit more outreach and case management with them, who we think are higher risk for development of a postpartum or peripartum mood disorder, and really assigning one of the social workers or in the Native community, a community health worker, to just reach out to them on a weekly or biweekly basis, and just continuing to have that persistent warm touch. And the other thing I would name is since isolation, we know, is its own independent risk factor, regardless of the independent risk factor of being pregnant and then newly postpartum, identifying your local support groups. And there's a lot of online support groups happening, at least here, and I know that there's been tons of yeoman effort in lots of different birth communities to create online childbirth education and online postpartum support groups and online lactation. And even just connecting women to those resources too can be a way to, certainly not if they have reached a point where they need mood stabilization and psychiatric intervention, but working to unwind the tightness and isolation that is happening in the wake of this pandemic would be another thing that we're focusing on as well.
Perfect. Courtney?
Oh, I just want to say thank you, Erin and Carrie, for sharing all of these amazing resources out there and identifying them. And just a reminder that we had our past webinar focusing on the mental health, and we have lots of resources also available on our joint resource website, and we will definitely direct you guys to that. So thank you. I'm going to shift the focus a little bit here and talk about the effects of COVID-19 in the newborn period. And also, I'm asking Pam to address this first and possibly comment on any high-risk infants that have BPD and differentiating that between COVID-19 versus RSV. Thank you, Pam.
Sure. So thankfully, the bright spot of all of this COVID mess has been that infants seem to be relatively non-susceptible to at least severe COVID. We certainly haven't been testing for asymptomatic infants, but we in our practice and at our hospital, as a matter of fact, have not seen any newborns with symptomatic COVID. Our numbers in Los Angeles are obviously higher than the rest of the state, but still very, very low compared to what our colleagues in New York are seeing. And I've been in contact with a lot of my friends who are pediatricians and hospitalists in New York where I trained. And they are seeing the same thing, that the young children really, really seem to be not showing symptoms. So vertical transmission seems to be very, very low worldwide. There's been some isolated reports here and there, but for the most part, babies born even to symptomatic positive moms have been negative. And we certainly haven't seen any rise across the country in children with BPD or even just older children with asthma. They don't seem to be more susceptible to getting severe disease. So all of that is great news for us in the pediatric community. I think, as the data comes in, we'll learn more and more. I'm sure, as with the rest of you, every week feels like the information that we had last week is now obsolete. But in terms of respiratory illness, the children across the board tend to do very, very well.
And Pam, this is Krista. Through the chat box, it's asking if there is a recommended period for separation for a COVID positive mom, like how long should she maintain that separation from the baby?
In an asymptomatic mother, it's clearly an inexact science, but the current recommendation is 14 days from the positive test that they should remain separated.
Perfect. Thank you, Pam. I've got a question for Elizabeth, and I just want to allow the panelists to know Robin in the moment in regards to telehealth or other options for access to care. So Elizabeth, I'm turning to you now. There's been much news coverage regarding pregnant persons seeking information about birthing outside the hospital setting, including home birthing. Can you speak to this and whether there's any data that pertains to this?
Thank you. Yes, so I am the director of a state licensed, nationally accredited freestanding birth center. So I can speak to this very directly. And there is some data out there about that. The California Nurse Midwives Association commissioned a study in April to ask community-based providers that included licensed midwives, nurse midwives, and physicians about an increase in inquiries for care and care. 95% of the respondents to the survey reported an increase in inquiries. And these providers reported on average about a 200% increase in their monthly inquiries. certainly for my practice, this is true. And my local home birth and birth center colleagues that I'm in regular contact are certainly working at or near their practice capacities for the last month and into and through the summer. What remains to be seen, however, is whether this increase in inquiries regarding out-of-hospital and community-based care is in fact going to lead to an increase in out-of-hospital births. I think that overall it will, but certainly that the increase won't carry the same proportion. Interesting, a large number of our inquiries have been from folks who are in fact not entirely appropriate for out-of-hospital or community-based birth. And they don't actually seem to recognize that, which is interesting in and of itself. So our first goal in conversations with these families is to do the really thorough risk-based screening that is the foundation of community-based care to determine if in fact this is an appropriate family for out-of-hospital birth. And if we determine they're not, we then move on to try to determine what's going on with them. Why are they turning from the care that they've established outside of the mainstream medical community? What are they looking for? And what we found is that folks are scared and they're feeling disconnected from their providers. And they have a lot of questions. And due to the nature of most community-based practices, we are smaller, we have a more intimate feel. We are really well suited to provide the comfort, the reassurance, and the education regarding the safest location for birth. So overall, yeah, we are seeing that. And it is both an exciting and a moment for concern to keep birth safe in all locations.
Thank you, Elizabeth. We want to go over a little bit to the tech side here, and whether that's telehealth or other technology, we want to broach the idea of checking blood pressures remotely. What's going on out there? I want to go to Erin, Dr. Saleeby. Can you talk to us about that and how you're using remote monitoring? Are there devices or apps you're using? And then also access to care. You know, we mentioned some expert mentioned earlier doing parking lot visits. Anything like that going on, or anything you could speak to?
Sure. I'm happy to report that we're sort of in the infancy of this grand telehealth experiment in LA County Department of Health Services clinics, and that we are rapidly trying to adapt new models of care to our multidisciplinary care teams for prenatal and postpartum care, including home visitation services. And I think the answer is that we don't know yet exactly what the uptake will be by our clients, and how sort of the best fit will be found for various activities, from health education to lactation services to standard prenatal care. I would point out that there was a recent systematic review that was published in the OBGYN Green Journal about telehealth interventions. And what we do know from the evidence is that remote monitoring for antenatal blood pressure checks, for glucose control, for asthma checks, that those telehealth interventions are known to have equivalent maternal and fetal outcomes with fewer in-person visits. And that's certainly a priority for us right now. In COVID, is to reduce the number of in-person visits that we require for our patients. And we believe that we'll be able to drive down the number of in-person visits to as few as possibly 5 prenatal visits if we focus them around lab draws and ultrasounds and things that really can't be done remotely. So we are using both phone visits as well as video visits. We're improving and enhancing our patient portals through our electronic medical records so that there can be more interactive knowledge sharing and patient education available. to our patients and to our providers in that platform. We are also looking at interventions to try remote initiation of contraception, and then also for self-injection of contraceptives like Depo-Provera subcutaneously in the postpartum period. There's great evidence for that practice, but it hasn't been widely adopted historically in the women's health field for a variety of reasons. That COVID now sort of helps us to get over that implementation gap. So I do believe that both blood pressure monitoring, which is again, it's a DME benefit of Medi-Cal plans for those of you who work in the safety net. So that should be available to your patients. Certainly glucometers, as you know. Scales remain one of these, like maybe you can get them kind of DME type of pieces of equipment that can enhance, home monitoring of pregnancies. But, we really believe that if we can find a way to get BP cuffs, glucometers, and scales to our patients, that we will be able to reduce the number of inpatient visits required. And whether by phone visits, SMS, texting, or video visits, that not only standard prenatal care, but also the enhanced services of health education, of mental health services, of nutrition counseling, may even be able to be provided through these alternative modes of communication that might even replace some of our face-to-face visits for years to come.
Wow, so much to digest. Thank you, Erin. Excellent. Sandra and Wendy, I'm going to give you a couple minutes each. If you could go ahead and tell us what's changing in your venues. How are you offering care differently? What other, technologies? What's different?
This is Wendy.
Hi.
Okay. I'll
go ahead, Wendy.
I'll go ahead and start then. So, as I mentioned earlier, most of our WIC agencies are closed to in-person services. So that means that we are providing everything remotely. We were really fortunate in California that earlier this year and the end of last year, we had gone to the WIC card. And so what that means is that all of the benefits, the food benefits, are loaded onto the card. So we don't have to have our participants coming in to the WIC site. We can do all of that by the phone. We can mail them their cards. The food benefits can be loaded remotely. So that's helped a lot. In terms of our education, again, I mentioned earlier that we are providing education in a variety of ways. We have education over the phone. We do text messaging where we send links to videos and to some of our WIC materials. Just for an example, we have links to our nutrition and breastfeeding pamphlets and booklets. We have video clips on how to assemble and use breast pumps, hand expression, latch. We have videos on baby behavior cues, crying and sleep for parents of newborn. And and the other thing I should say is that our regional breastfeeding liaisons throughout the state of California are putting together resource lists of virtual prenatal education classes, prenatal breastfeeding classes and support groups, childbirth classes that are happening in the community, and making those available to our participants as well, so we can make sure that they're getting the education that they need. We are not doing a lot with video conferencing yet. We have a few agencies in California that are starting to do some of that. Some of them are using FaceTime, for example, some Zoom, but we're waiting on hopefully a state contract so that the local agencies will have this available, and then we're going to be doing training for all of our WIC staff on how to use all of that.
Perfect. Sandra, anything you'd like to add, or we're getting close to our final question here?
I understand that completely. Thank you. I think the topic of high-risk infant follow-up in the virtual world actually warrants its own webinar, and hopefully that will be coming soon. But we have transitioned to a completely telehealth-based approach for our program. We felt it was really necessary to stay connected with our children and their families, especially during shelter in place. And we've identified a lot of stress for families, worried about barriers to accessing care and developmental support for their children. Along with, we've identified a lot of financial and emotional stressors on parents. So we've been able to successfully create a telehealth visit where we've been able to review the overall health of the child, discuss medical concerns and problems, discuss development and worries, and also we've been pleasantly surprised that we're able to actually assess a good portion of development via the telehealth visit with parents. And children are actually often more engaged and more comfortable in their home, and we can get them to interact with us much more easily than sometimes in clinic. We're also working to advocate for services and partnering with services in the community that are transitioning or trying to transition to a telehealth model. A lot of our education is very similar to what Wendy mentioned. We additionally have our developmental and behavioral website has additional resources in place. And yeah, thank you.
Thank you, Sandra. Next slide, Valerie. We are so grateful to all the experts who have presented today. In a moment, I'll share the Cme Info. Next slide. We want to remind everybody that every hospital, every affiliation is working with a different set of resources and constraints. It must be applicable to your setting. And as this is rapidly evolving, we encourage you to take into consideration the most recently available local health department and CDC guidance. Next slide. Here is a Cme Info. Simply searching for Cme Stanford Medicine will get you to the right spot. This session is identified as 35919. And nurses out there, please remember, in the state of California, you can use AMA Category 1 units towards your continuing education. Last, please. Before I hand it over to Dr. Main, I want to remind you that the slides and the webinar recording will be available at californiaperinatalprograms.org. You're seeing the first or the top of our website page. This is curated weekly, and I want to thank Krista Sikowski, Courtney Nisbet, Henry Lee, and Elliot Main for really curating this website content of all our patients. So Elliot, I'd love it if you could leave us with some closing thoughts as we head into the weekend. Thank you, everybody.
Thank you, Christina. I think I'd like to leave you with two key points. First, for the last 6 weeks, we have been focused in hospitals in the healthcare system on dealing with COVID positive moms. What is the PPE? How can we handle a surge? How are we going to protect our staff? All these issues were front and center as we were waiting for something to happen like what was happening in New York City. That did not happen in California, but who has been clearly left out of this equation is the 99% of the women who are not COVID positive, but are at home in isolation with increasing anxiety and worries, not only about their health, but their economics, et cetera. And I think we need to recognize that, and I would propose two things that we really need to do a better job of. And one is communicating with what to expect on labor and delivery and how we really are here both for your safety and for your birth experience. And two, we need to ensure that there are touches, and you can't have enough touches here, whether it's phone calls, little video chats by your staff or others, but the more times we can touch, the better we're going to be in terms of addressing some of the mental health issues. And to that end, we've been putting together an example document for education for the non-COVID positives. There's lots of examples of education materials for COVID positive out there. This has obviously been an evolving document over the last couple of weeks or months, and is anticipated that each hospital will have to adjust it to fit its local circumstances, but we need to do a better job of communicating. The second point to leave you with is each time we have a large-scale social disruption that often leads to a disruption in how we provide care, that leaves us an opportunity to evaluate new ways of doing things. And I think that's the real opportunity that's presenting us today, is we've learned a lot about how to do telehealth, how to do perhaps reduced visits, and making things more efficient for our patients, being in a patient-centered way. I always love Dr. Saleeby's comments about her goal is to get her pregnant women off the freeways in Los Angeles. And that is actually a pretty worthy goal. Can we do a as good, if not better job with fewer visits or fewer in-person visits with the same outcomes? And those are good things to think about as we go into the weekend. Thank you all, and thank you for joining us today.